On behalf of McLaren Macomb, hello and welcome to this educational program on avoiding and treating geriatric fracture. I'm Kelly DiNardo, your moderator. We will be hearing from Dr. Michael Milshteyn, an orthopedic surgeon at McLaren Macomb. At the end of this presentation, Dr. Milshteyn will be answering questions that you might have. Please use the chat feature to send in your questions. Dr. Milshteyn, thank you so much for speaking with us today.
No problem, Kelly. Thank you. Thank you for having me. Hi, everybody. Welcome to this webinar on bone health. Like Kelly said, I'm Dr. Milshteyn. I'm an orthopedic surgeon specializing in trauma surgery. I specifically deal a lot with fractures and elderly as more and more fractures happen in the elderly population due to osteoporosis. In this webinar, we'll talk about what is osteoporosis, why is it important, why are we talking about it today, the medical treatments, the nutritional and exercise treatments that you can do to prevent osteoporosis, fall prevention, and some of the tools and resources, and of course, question and answer afterwards. So osteoporosis is really a disease that occurs when the body loses too much bone or makes too little bone, or both. As a result, the bones have become weak and become more frail and more suspect to fractures easily from things as small as a minor bump or even sneezing. When you're younger, you're not going to experience these fractures because your bones are strong, but as we age, our bones can become weaker due to osteoporosis. So this is a kind of a cool picture of a normal bone that's really, really magnified. It's very, very dense. And that's how our bone looks when we're young. As we age, the osteoporotic bone is on the right and the normal bone is on your left. And it shows you how much more holes and cavities we have. And that makes that really complicated, amazing architecture of our bones weaker and more susceptible to fractures. It's common, approximately 10 million Americans have it, another 4 million are at high risk. About half of all women will experience a fracture who are over 50 because of osteoporosis. And 1 of 4 men will too. And we often think that this is more affecting women, but it does affect older men. These are some of the financial implications of this: 19 billion in costs, 2 million in fractures in 2005, and just going to go up as far as our population ages. We will be having more fractures and be responsible to more costs to our healthcare system. These are the most common fractures that we see in osteoporosis type patients: vertebral fractures, wrist fractures, and hip fractures. I'd just like to outline those and kind of what we do for them as orthopedic surgeons, and why, kind of to highlight what the impact of these fractures are and why it's so important to prevent them and treat them. So vertebral fractures happen as back pain sometimes. And you can see kind of, if in the top right corner, you see this kind of really crunched down vertebral body, which is an x-ray of your back. And our treatments are used to decrease pain and increase mobilization in these and restore function in these fractures. And some of the treatments would be as small as a brace sometimes, and that helps continue control the pain and help people mobilize. Or it could be a procedure called a kyphoplasty, where we put cement into the lumbar spine to help with the pain. Wrist fractures are very common after a fall and an outstretched hand, and have some deformity and wrist pain associated with it. Again, we have treatments to restore the function. And that can be a cast sometimes, and sometimes it can be significant enough to have surgery with plates and screws, as you see on your right. Hip fractures are also very common as we age, landing on one side of the hip joint, hitting it, and then not being able to really walk afterwards. That's a medical urgency, and usually patients present to the ER because of this. And sometimes people even have pain, they can walk, but they have continued growing pain, and that's something that you don't want to leave unaddressed. Surgery for that, can be fixing it again with plates and screws, or it can involve a total hip replacement or partial hip replacement. All these are obviously things that can impact a person's lifestyle, their mobility, their ability to use their arms, legs, and have significant effect on a patient's life and their quality of life. So before we talk about what we can do to help our bones become more resilient to fractures, let's talk about the things that they're made of. They're made of things called collagen, which is a protein that makes bones flexible. Calcium and phosphate are minerals that make bones hard. And then there's bone cells that remove and replace weakened sections of bone. And our lives are a constant process of these cells making and breaking down bone as we age. And as we age, our skeleton loses old bone and forms new bone. Children and teenagers make bones faster than they lose old bone, so bones get stronger and they grow. After you reach peak bone mass, we're talking about age between 20, 25, there's the balance between bone loss and bone formation may start to change. And usually in midlife, bone loss actually speeds up in both men and women. So you're actually losing more bone than you're making. And osteoporosis is when you lose too much bone and make bones, or you make too little bone. The more bone you have at the time of your peak age, the better, because then the amount of bone you can kind of afford to lose will be more. And so it's more protective at that point. And so that's why it's important for kids to have the calcium in the milk to build up their bones as strong as they can to the point where they have more bone reserve. So who gets osteoporosis? Well, older people, more than younger people. All of us will get it at some point as we live, if we live long enough. It's not true that every older person gets osteoporosis, but it is more common. And about half of women in their 80s will have it. So this slide, I chose this picture to really kind of outline the typical patient you would have with osteoporosis. So somebody who would be female, older age, family history of osteoporosis or broken bones in their, whether it be their mom or dad. Being small and thin, because again, talking about that bone reserve, they didn't have as much bone reserve to work with. Race and ethnicity does play into it. People of Caucasian descent, Asian or Latino descent are more likely to have osteoporosis. And hormonal changes, changes in hormones as women reach menopause. They have low hormones. Estrogen and testosterone are actually protective against bone loss. And so in the cases where menopause hits in most women, estrogen becomes much lower and they're more likely to have fractures. So diet. Calcium is the most important mineral for healthy bones. And that's because it's a building block like we talked about. And vitamin D is the most important because it helps your body absorb calcium. So vitamin D and calcium really work together to help your bones be healthy and have strong bone health. There are other things that are involved. Magnesium, vitamin K, all these vitamins have a role. Proteins have a role. It's good to have protein in your diet, and that's good for your muscle growth as well and maintaining your muscle mass as you age. But having too much can cause a loss of calcium through your kidneys. Caffeine appears to decrease bone absorption. So having too much caffeine, we're talking drinking more than 3 or 4 cups of coffee. So having 1 cup of coffee is not a big deal, but going too much with the caffeine can lead to low calcium absorption and decrease your bone density. Sodium, a lot of sodium may reduce your body's ability to retain calcium. So again, too high salt of a diet can be significant. The American Heart Association sometimes will put recommendations of less than 2,100 milligrams of sodium per day. Now, lifestyle risks, inactive lifestyle. We know that people that have active lifestyle and constantly loading their body, so because bone reserves, and we'll talk about later about exercise, but the body reacts to more weight on the bones, and the more weight you put onto it, the more healthy your bones are. Smoking is detrimental to bone health. It actually kills some of those cells we talked about that help build bone. Alcohol abuse can decrease not only your absorption of nutrients, but also people with alcohol abuse just have poor diets, so they don't get as many of the nutrients that we need for bone. Certain medications, like a steroid medication, there's complete lists online that I'll reference later on to some resources you can go to see the complete list, but steroids are one of them. And then certain diseases like rheumatoid arthritis, thyroid disorders, and GI disorders lead to malabsorption of calcium, vitamin D, and lead to poor bone metabolism. Again, full lists are available on several resources I'll direct you to later on. So how do we prevent bone loss? Getting enough vitamin D and calcium. It sounds simple, but it is something we can all do through the foods we eat and some of the supplements we can take. These are some of the numbers that adult women need, and you can see they change throughout as we age. So over 50, you really need about 1,200 milligrams of calcium per day, and so do older men, 70 and older, need as well higher dose of calcium than we did when we were younger. Vitamin D also changes requirements as we age. When we're under 50, it's 400 to 800, but as we are 50 and over, it's really 800 to 1,000, and as well as men over 50. And that value, that 1,000 value, is really for people that don't have osteoporosis. Sometimes we ask for patients with osteoporosis to have higher levels, or have fractures. We ask them to have higher levels of vitamin D, especially. As well as calcium. Not every calcium supplement's the same, so you really want to pay attention to what the serving size is, as far as 1 pill or 2 pills, and how much calcium is actually per serving. Your pharmacists are a really great resource for what calcium supplements are good for you and don't interact with your medications. Take supplements with food whenever possible, because when you take it with food, it helps your absorption of the vitamins. Antacid medications can actually be detriment to calcium absorption, so be wary of that. And then sometimes you can use calcium citrate instead, which is a more absorbable, doesn't need the stomach acids as much, which those medications decrease to absorb. Vitamin D, it's everywhere. Our skin actually makes vitamin D from the sunlight, but in Michigan, we have problems with that, with being being a lot of time in the winter and having less sunlight. So that's why we have to really rely on supplements and multivitamins and combinations with vitamin D. And it's really in Michigan, I think, that most people are vitamin D deficient, and we just don't know it because we don't get it tested as much. So exercise can really help with your bone health. Your muscles get bigger and stronger with exercise, but so do bones. They get denser and stronger. The impact of your weight or more, so your body weight, with just weight-bearing exercises can help your bone health. So there's weight-bearing, which are impact exercises, and then there's resistance training. Both help your bone health in varying ways. With weight-bearing, I mean by walking, running, stair climbing. Those are all weight bearing. So your weight's actually on your bones and it's loading those bones, which is promoting them to remodel and get stronger. Biking and swimming are really great exercises for your health, your heart. Even people who have joint pain, like arthritis, it's really great because it's non-weight bearing. So biking and swimming is not a weight bearing exercise that helps with bone health, but it's maybe good for your health overall. As far as the recommendations out there for exercise, really 30 minutes on most days of the week of light exercise. So even if you go for a walk for 30 minutes, you're doing your role for your bone health. Resistance exercises are moving a weight or some type of resistance against gravity, functional movements, lifting weights, using elastic exercise bands, and weight machines. These are, again, load extra weight on your bones, and just 2 to 3 days a week is great. One exercise for each major muscle group for a total of 8 to 12 exercises. So even if you can mix in some weight resistance and weight bearing exercise, really can do a lot for your bone health. Other exercises that may help just to prevent falls, which will be the next part of our talk, are balance exercises, posture exercises, having a proper posture, and functional exercises. All of these really help your coordination and your overall strength and prevent having future falls that may impact you as far as fractures are concerned. So how do we detect osteoporosis? Bone mineral density is really the gold standard that we have, and I'll go into details about that. Something about a FRAX score, and of course, laboratory tests. Laboratory tests are for vitamin D, calcium, and things like thyroid conditions and hormone levels. These are all can impact your bone density, and these are something your doctor would take a look at. This is a picture of a bone density machine. So it's basically uses different parts of your body, and then it compares the bone mineral density of that part to what a normal population would be, somebody who's in their 20s. And sometimes we do serial tests to see the trend of bone loss and maybe some changes as you take a medication for osteoporosis to see if your density is increasing or decreasing, or is it staying the same. So sometimes it just is a trend. So who needs this test? Really, these are the overall recommendations. Any postmenopausal women under age of 65 with one or more risk factors for osteoporosis, men 50 to 69 with one or more risk, women 65 or older without any risk factors, men 70 or older without any risk factors, women or men 50 or older who have broken a bone that are low energy, meaning just like ground level fall. So this is not a motor vehicle accident or fall from a ladder or a roof or things like that. And then postmenopausal women who have stopped taking estrogen therapy or hormone therapy. As we know, estrogen therapy and hormone therapy are one of the types of therapies that we use to help with other medical conditions, but also bone health. So when you go to a doctor and you get a DEXA scan, you're going to get something called a T-score, and that's how your bones compare to those of healthy young adults, like I said before, somebody in their 20s. And they describe this as a standard deviation, or how much do you deviate from the average in the people with strong bones. So a bone mineral density equals about 10% to 15% drop in bone density is to one standard deviation. When you're more than 2.5 standard deviations below normal means you have osteoporosis. So to the left is just a graph and it's showing somebody who has a -2 and a -1.8. So basically this is just an average of what their bone density is. Now a FRAX score is really an interesting score that they use with the DEXA report, and it incorporates your density and some other risk factors for osteoporosis, and it determines your risk of having a fracture in the next 10 years. It's a useful tool just to help you predict and have another conversation with your doctor and help discuss treatments for osteoporosis, whether you should be one of those people that is on medications for it. So how do we treat? One of the ways we treat is to prevent bone loss and then and fractures in the future. There's two types, one that are anti-resorptives that prevent the resorption of bone, and ones that are anabolics that basically build bone. So like I said, the anti-resorptives break down the bone. The rate of bone formation may outpace the rate of bone loss. So effectively, you're increasing the bone density. Drugs that I'm sure you've heard about, like Fosamax, Boniva, and Reclast. So these are all that medications that try to put the balance in your favor. So you try to prevent the amount of bone you lose so that you maintain a certain level of bone mass. There's hormone-based therapies like estrogen and other ones like Duave and calcitonin and Prolia. These are all medications that are hormone-driven. You know, there's been a lot of controversy in the past about estrogen and its use for osteoporosis, and that's something you should talk about with your primary care doctor about the risks and benefits of that. But there's a lot of these hormone-based therapies to help with bone loss. Now there's anabolics like Forteo and Tymlos, and they're really indicated for patients that are high risk for fracture. And they speed up bone formation, and they work with the hormones and the hormone receptors that help build bone in the bone cells. So there's a lot of treatments out there, and there's a lot of factors in choosing a treatment for you. Really, your age should be something you consider. Are you older or younger? Whether if you're female or male, would direct, because some of these therapies are specifically indicated for males or females. Your menopause status, you know, when did you reach menopause? Were you younger or were you older? That definitely has a sense of where your bone health would be. your severity of osteoporosis. Or do you have osteopenia, meaning weakness of your bones, or are you osteoporotic? And so that really changes your decision making. Other medical problems, do you have other medical problems that may be contributing? So that may cause you to either change your medications or change the type of drug you take. And of course, personal preference is always a factor. Really, you can take these medications for a while. Some of these anti-resorptives, you have to have what's called a therapy holiday, which they say that you take them for a few years and then you take a break because they can have some side effects that each drug has its own. But one of them is actually increasing chance of some atypical fractures. Anabolics, as far as we know, you can actually don't have to have a holiday with them. You can keep being on them to build up your bone mass. The major thing is really in preventing fall risk, and no talk about osteoporosis would be complete without how do we prevent falls. And to really prevent fractures, keeping fit, and then working on balance and coordination, and then of course, fall proofing your home. So as far as the home and that in general, if you have osteoporosis or a risk for fractures, you should really remove all the loose wires and cords and throw rugs in your home. Keep the floors free of clutter. Sure, all carpets and rugs are of skid-proof backing or tacked onto the floor. Do not use slippery wax on bare floor, and keep furniture in really a designated area. These things are just prevent you from having accidents and prevent having fracture. And most of the injuries that I treat as far as osteoporotic fractures happen in the home. Bathrooms, grab bars on the bathrooms and the walls beside the tub. Non-skid rubber mats and non-skid even adhesives are great to have on stairs, even not just in the bathroom. Plastic chair with a back and non-skid legs in the shower if you require sitting for the showering. In the kitchen, again, non-skid mats, cleaning up spills as soon as they happen, not leaving appliances or cupboards open because they can be all of a sudden this unanticipated hazard that you have to navigate around. The bedrooms, placing light switches within reach of your bed and a night light between your bedroom and the bathroom so you can illuminate if you have to get up in the middle of the night, as often people who are older do. Getting up slowly from sitting or lying, since this may cause dizziness and cause you to fall. Keeping stairs well lit, having sturdy handle rails is a must, and make sure carpeting is securely attached if you have carpeting on your stairs. So osteoporosis really in summary will affect men and women throughout their lifetime. It's something we can't avoid. It will affect all of us. The consequences can be prevented with some medical treatment, diet, physical exercise, fall prevention. All these things together, I think, are really important to keep you safe and keep your bones healthy. And it's also important to really discuss your bone health with your primary care provider when you have your checkup. Sometimes there's just other issues that we are really at top of mind, like our heart, which are important, and our other health issues. But really, it's important to discuss your bone health really at every visit and see what you're doing, or is there anything that needs to be done. These are some online resources that are very helpful. The National Osteoporosis Foundation has a lot of really great literature, has a lot of really great places to go, and even specific suggestions, people you can speak to about if you have any questions. American Bone Health is another great organization that has some great resources, even a calculator to calculate what your bone health is, and as far as your risk for fractures. It's especially helpful if you have a DEXA scan number, because then you can just plug it into the website and find out what factors will affect your bone health and if you're at risk for any further fractures. So that's my information. If you ever want to have an appointment to discuss your bone health or any fractures that you may have, be happy to see you and discuss that. But at this point, we'll turn into any questions that you may have.
Thank you so much. That was really great information. I do have some questions, and for Any of you that are listening, if you have any questions, please just add them in your chat box and I will read them for the doctor. So my first question here is, you mentioned people in Michigan tend to have lower vitamin D levels in the wintertime. If someone's already taking a calcium supplement that has vitamin D in it, do you find that people may sometimes need an additional vitamin D dose? And do you recommend having blood levels drawn? If so, like when should people have them? Like, is there a specific month?
Sure.
Would you want them to have it like early winter?
Sure, yeah, that's great. The seasons vary that. So the first question about the vitamin D and calcium, I think it just depends on the box, just to see what the dosage is, really. I think that sometimes they're underdosed. I find a lot of supplements have 800 international units of vitamin D with calcium. So they have enough calcium, but not enough vitamin D. So I think that just looking at the label and supplementing it as needed, I think that 1,200 milligrams of calcium is really standard at this point, and 1,000 units to sometimes 2,000 units of vitamin D is on a daily basis is good for elderly. As far as nobody really knows when we should draw these levels, but I think that having your blood levels drawn at least once a year with your checkup is a good idea, just to get a baseline and see where your levels are.
Should I avoid eating beans or legumes or wheat bran if I have osteoporosis?
I don't think you should avoid it. I think that they do sometimes decrease absorption of calcium, but not to it's just to use your judgment, and having a little bit of that doesn't really, I think, affect the overall absorption if you're supplementing well and you're eating a good healthy diet with enough calcium and eat milk products and yogurts and things like that. I think it shouldn't be too much of an issue.
Here's another question. Are there exercises that I shouldn't do if I have osteoporosis?
So I think that the exercises you shouldn't do are very kind of fast twitch movements, like a lot of twisting and very fast bending and things like that. But think about slow motions, walking, slow lifting, slow resistance band, just kind of taking your time. Any aggressive movements, I think, can cause you to lose your balance and have an increased level for fall. I think doing exercise like on a platform with somebody who has bad balance could be a problem. So it's not so much that the movements themselves, it's more kind of putting yourself in a situation where you could lose your balance and fall.
Here's a question about Prolia. In regards to Prolia, after how many years of treatment should you consider taking a holiday?
So the current literature says about 5 to 7 years, of treatment. You should consider talking to your doctor about taking a holiday for 1 to 2 years. I'm not exactly familiar with exactly what the Prolia recommendations are, but in general, the recommendations for those type of drugs is about 5 to 7 years of therapy and then taking a break and then restarting it again.
Another question, can I rebuild my bone density?
Can't really, I wish we could. Some of the drugs that are the anabolic drugs, that's what they do. They try and rebuild your bone density. But the big thing is really to prevent the loss. And that's what really we can do very well. We have shown that by doing the things in your diet, your exercise, the supplementation, you can really prevent it, avoiding some of the things that, maybe some of the drugs that cause the osteoporosis or the hormone levels. Those are the things we can do. And one of the things I didn't mention in my talk, but when we have these serial DEXAs, so let's say you're taking medication and you've been diagnosed because of osteoporosis, and you do a DEXA scan a year later, some people are very discouraged that their levels don't go up. Sometimes we just don't want them to go down, really. We want them to maintain. And sometimes that's really a win in the medical community, that we're maintaining your bone health and not decreasing it. So
I know that you are part of the trauma program here at McLaren Macomb. Can you talk about like the types of injuries? What are the most common things that you're seeing there at the hospital? Are they related to falls, and how does osteoporosis play into that?
Sure. Our trauma population has really changed over the years. We used to see, an orthopedic trauma surgeon when I was in med school was, somebody who took a lot of care of a lot of car accidents and motorcycle accidents, which I still do to this day. But I would say about 50% of trauma has changed to the older population. Really from falls, shoulder fractures, wrist fractures, hip fractures from falls. It probably we treat about at least 2 to 3 a day in the hospital. They're from ground level falls.
It's so important to get rid of those throw rugs, right?
Yes, very.
Yeah. I think that's all the questions that we had. So again, thank you so much for this information. It's really valuable for our audience.
No problem. Thank you so much for having me.
Yeah. Okay, everyone, have a great day. Thank you so much for joining us.
Bye-bye.
Bye.